It's very important once you start someone on a therapy to monitor their response to it. There's several steps to that. We obtain MRI scans 3 months after someone starts a disease-modifying therapy. Some of my colleagues prefer to wait 6 months to give the drug more time to run in, but that scan becomes the baseline scan for which we then assess the therapeutic response moving on, and we'll do an annual MRI after that. And so one monitors both for clinical attacks and for MRI activity. But I have to say that we have not yet developed metrics to say, well, if you have 1 new lesion after 1 year or 3 lesions after 2 years or something, that's an indication to switch. We don't know yet what the threshold is for which you would say that that drug's having an inadequate response. While we like to have individuals with no activity whatsoever, clinical or MRI, that's not necessarily the reality of the drugs we're dealing with. We're also thinking about monitoring more closely with other metrics such as ocular coherence tomography and cognitive function. So we've started now doing cognitive testing on all of our patients, also on an annual basis, to see if that gives us a signal to tell us that someone is moving along or not doing well.
Once a patient has been on an MS therapy for 6 or 12 months or even longer, we're faced with a question of, is it working? Should we continue it? And really, there are 3 main ways we are looking at it. 2, we're looking at it from an efficacy point of view. What's happened with the patient's relapses and what's happened with the new lesions and MRI. Ideally, the patient has had no clinical relapses and has had no new or active lesions or enlarging lesions on their MRI. Now, we do use MRI to guide therapy because it becomes a more sensitive measure of the disease activity than just clinical relapses alone. We don't ignore the relapses, but we use the MRI to augment our understanding of the disease activity and what the therapy is doing. Ideally, we want no relapses and we want no new lesions on MRI or active lesions on a gadolinium-enhanced MRI. Where we exactly say 1 is too many, whether it's 1 lesion or 1 relapse, is a judgment call, and it depends on how severe the relapse is, how much residual deficit, what the patient's tolerance is for an additional new drug that may have more risks. And also the same for MRI. How many new lesions? How large is the lesion? How damaging does the lesion look to be, or lesions on MRI? The third part about considering a therapy is how a patient is tolerating it. So patients may have side effects, may not like the administration, for example, an injection. There may be safety concerns. A patient on natalizumab may have developed seropositivity for the JC virus and thereby has an increased risk of the brain infection, PML. And so by looking at side effect and risk profile, we can make some decisions as to whether we recommend the patient stay on that therapy or move to a different therapy. When choosing the next therapy, in part it depends on why we're moving from the first therapy. If we're moving from the first therapy because of a safety concern or a side effect, we might think of moving laterally, like from one oral therapy to another therapy. If it's because of disease activity, either clinical relapses or new or active lesions in MRI, we will generally move up in the intensity of the therapy, from an injection therapy to an oral therapy, or from an oral therapy up to an infusion monoclonal antibody therapy.